Just want to thank the conference for having me here, and it's my first time here, and I love the energy and the warm hospitality that I've received here at this conference, so thank all of you as well. Yesterday, I kind of talked big picture about working in correctional settings and some of the big picture issues. Today, I want to talk about a specific project and some of the challenges that we've encountered in the project. So this partnership involves a wide range of institutions, health departments, correctional facilities, in carrying this out. And what we were aiming to do is implement and evaluate a comprehensive seek, test, and treat program for people in being released from Wisconsin prison system to Milwaukee County in Wisconsin. Milwaukee County is the largest metropolitan area. It accounts for about 60% of all the HIV cases in Wisconsin. And they've seen a explosion in HIV amongst African-American MSM over the last 5 years, where they estimate now about 40% of all African-American MSM are HIV positive. We've been arguing that they better start doing prevention with women, because over a 16-year period, we know about 35% consistently in surveys are bisexually active, and so it's going to cross over, but hasn't there. In Wisconsin, they test everybody coming into the state correctional system, which, as I understand, is probably closest in parallel to your federal system here. And we have it's voluntary but routine, and about 95% of people get tested. But in the detention facility, which is where people who get probation and parole revoked or other sorts of substance abuse treatment charges, they do not do any testing. So what we were trying to do is fill that gap in there, linking anybody who's known positive or newly identified positive to treatment at the AIDS Resource Center of Wisconsin, which is the largest treatment provider, and then identifying high-risk negatives that we could get linked into a program run by ARCW to try to recruit high-risk members of their social networks in for testing. And they've been doing this with injection drug users, and they've gone from about a 0.51% hit rate in the STI clinics to about a 3 to 4% hit rate through this high-risk testing program. So seems to have a cost component to it. We also are looking at intensive analysis at the cost and cost effectiveness of this. And I'm not going to go through all of this, but that we're doing very detailed cost analysis to see, is this really an effective strategy in terms of trying to do comprehensive testing? Okay. As I mentioned, most people that go into the state system are already tested, but testing is not routine in the detention facilities. So in our study, people that come into Milwaukee Secure Detention Facility, within 24 to 48 hours, we approach them about being tested and being in the study. For those that are willing, they take an ACASI survey of risk behavior, they do the HIV rapid test, and then they come back and do an individualized risk reduction program on a computer program as well. Okay. So at the end of the day, we have three groups, those that are either known positives or have a reactive test. And if they have reactive, we do confirmatory testing. Those who have a non-reactive test, but their behavior puts them in the high-risk group, which is, in this particular study, is having unprotected sex, well, just having sex with an HIV positive partner, or using hard drugs, which is drugs other than pot, so heroin, cocaine, things like that. And then we have those that do not meet the criteria, low-risk negatives. The people in the reactive group get confirmatory testing, and positives, as I mentioned, are linked to comprehensive treatment. The high-risk group receive additional intervention and asked to refer other members of their high-risk networks upon release to come get tested at ARCW, and the low-risk group is done with the study. Okay. And this just gives you a brief sense of the sort of stuff that we're assessing in our risk behavior. We're trying to keep the survey down to 30 minutes, so we didn't go into a lot of psychosocial stuff. Okay. ARCW is a large comprehensive treatment center that provides both medical care and psychosocial services and mental health needs to people with HIV. They serve about, right now I think their client loads are around 1,000 to 1,100 clients. So they're a very large medical provider, a private community-based organization. Okay. You can see the things they include: comprehensive treatment and services, general health conditions, medical treatment, medical case management, life care services, and they also use electronic monitoring of medical records. One of the things that we really want to assess is, can we get guys coming out of prison who are positive into the electronic monitoring records so that they have a medical record they can take as they bounce around the system. Treatment evaluation. Again, I'm going to kind of go through this fast because I really want to get to the implications, but it's very thorough. It's standard of care that they offer in their follow-up of all the patients. And the guys coming in this study, they receive ARCW standard of care. There's no positions put on it by the study. It's really just a referral to standard of care, and then ARCW takes over as they would for any other patient they have. The high-risk negatives get additional training, as we mentioned, to recruit other members. And what we're testing there is, does this strategy work? Can we get people that might not otherwise be tested into testing? And do we increase the incidence of new HIVs that we find through this methodology, as we have with injection drug users? And again, we have a lot of cost data. I'm not going to go through all of this, but if anybody wants the slides, I'll be glad to send them to you. Okay. So what I really want to talk about is sort of yesterday I talked about sort of big picture challenges. What I want to talk about now is some of the challenges that we've had to face in this particular study, which is still ongoing. Pre-study, building relationships and understandings. What is it that, prisons are very hierarchical, as we talked about yesterday, and it's one thing for the Bureau of Health Chief or the Secretary of Corrections to say, yes, you can do this study in this facility, but it's another thing when you get down to actually working with the guards and the social workers and the wardens of particular facilities and saying, okay, how do we actually carry this out within the structure of your facility? So, we had a lot of meetings up front to try to reach understandings, to understand what we could do, what we couldn't do. Study space is an issue because a lot of prisons don't have spare space. In this particular study, we have 2 rooms. One of them is a closet that was cleared out, and we use for HIV testing so that we can have private testing, but it's something that you always have to challenge with in correctional research. Clearance and storage of equipment. So we're doing HIV testing. We have needles for confirmatory testing. So how do you start to bring all of this equipment in and out of the prison? What we were able to work out is actually lock storage in the nurses' station, where we have a cabinet that we can lock up our supplies. But we literally have to, when we first bring something in, we have to account for every piece of equipment, every needle, every rapid test, and we have to keep a daily log. And then once a week, the prison actually monitors to make sure that if we said we use 50 kits, that the numbers match up. So we have very tight procedures in terms of inventory on that. And there are prisons that will not allow that type of equipment into their system at all. Okay. Staff security and clearance and training. All staff have to go through criminal background checks. And so if you're going to work in this situation, you need to let your employees know ahead of time that prisons don't really care about their privacy. And if there's something on their record, they might as well tell me now, because if not, the prisons will tell me. So I'm going to know one way or another. But it's something that, we spend a lot of time. And it doesn't preclude people from working in the prisons. But if they lie, they're done. And that is something that's really strict. So it's some of those things I spend a lot of time up front when I hire people and when we bring them, talking about this sort of issue. And then typically the prisons require you to go through their security training. The bottom line message of their security training, beyond all the do's and don'ts, is security is our priority. If something goes wrong, you've signed away your liability for any damage that might happen to you at the expense of us preserving security. I think is sort of my take-home message from that. But it is something that your staff has to be comfortable with and willing to sign those types of waivers. Decline in admittance due to policy changes. One of the things when we first planned this study, we had about 600 people a month being entered into Milwaukee Secure Detention Facility. It's down to about 450 now because they've made changes in trying to divert people to community corrections. That obviously has an impact on our research design in terms of the numbers that we could potentially recruit. So you have to always be prepared in correctional settings to have these sort of fluctuations. Once we started the study, personnel turnover, corrections tends to have high turnover of personnel. And so one of the things that's really important is to really get good policies kind of institutionalized so that when the new person comes in, you just say, well, here's the policy that was already agreed upon, and you can have some continuity. But it doesn't always work smoothly, and sometimes you get a new person that's got a different focus, different belief about how things should get done, and you have to adapt on the fly. Scheduling issues. When we first were told we could go in there, we were told we could be in there from 8 to 5, which was perfect. Nice morning block, nice afternoon block. Subsequent from the time we got funded till we actually started, they had developed a whole new programming regimen for the morning, which wiped out any morning recruitment. So we had to adapt and go afternoon and evening. Problem in the evening is they often have daytime, room time, which is when guys are out of their cells wandering loose, don't necessarily want to come do a study when it's time to watch TV and talk to their girlfriends. So we've had to make a lot of adjustments around trying to structure, and what ends up happening is my staff ends up working a lot of splits shells where they'll come in for 3 or 4 hours, go home for 3 or 4 hours, and come back for 3 or 4 hours to try to accommodate the way we can work in the prison. Getting reliable facility-based intake data, one would think it would be an easy thing to say, how many new people did you have come into the system? The problem is finding out the right person who actually knows that information. We were told, again, about 600 people. Well, we found out, that was talking to the higher-ups. When you actually talk to the people, the guards in the front line, we found out about 100 of those people were actually people coming from out of the county for substance abuse treatment that really weren't in their total numbers. We had other people that were up on different units that we couldn't access. So our denominator kept shrinking. And it took us a long time to actually find a person. You know, all I wanted to know is how many people walked through this security gate right here. And so some of these things that we think would be real simple, not always the case within correctional settings. And it's important that you have that so you kind of can know your retention rate. So recruitment issues, the way it works is people, we get a daily log from the guards when my staff comes in through the gate. We recruit people from the people that have been our most closest or have been in there the longest to the people that are most recent so that we can, you know, hopefully have a latency of a couple days if we need it. We recruit people not through correctional personnel, so the first point of contact is through the swampers. Swampers are guys that are in there for longer periods who have freedom of movement within the social. They're guys that are cleaning the areas. They have a lot of privileges. And so they're trusted by the other people coming in. They approach, tell them about the study and ask them if they would come talk to our staff. If they reach our staff, then we go through the full information disclosure and consent process. You can just kind of see, we started July 1st. As of last week, we've done almost 1,500 people come through the gates. About 7% of them are repeats, where they've been reincarcerated during that 4-month cycle. And we've been able to contact about 94% of the people that have come through to see if they're interested. Our enrollment rate right now is about 65% overall of the people that we actually contact. We're about 68%. You can see some of the top reasons. We're trying as much as possible to ask people who don't participate why. Just some don't want to be in a study and they don't want to give a reason. Guys, I'm not going to tell you. One of the unknowns that we have is we don't know what percent of that group might be known positives that just don't want to disclose, and so they choose not to be in the study. And we've had very surprisingly, Wisconsin historically runs about 1 to 1.5% seroprevalence in the prisons. We've had 4 known positives and 1 confirmed new positive in the entire study, which in one way, I'm very happy for it that we're not finding it. It's also very surprising given historical sort of incidents. Consent, privacy, and confidentiality issues. Private consent is not feasible. We have one big room that we could do all the assessment stuff in, and typically there's 3 to 4 people in there at a time. We do give people the offer of a private consultation if they would prefer through the consenting process. We use ACASI with headphones so that there's a privacy in doing the assessments. And what we do is basically put people with their backs in the corner, like we have a person in this corner, person in that corner, a person in that corner, but all anybody can see is the back of the computer screen. So that there is a degree of privacy within trying to do that. Otherwise, it just would not be feasible to get the numbers. I think people have been very receptive to the thing. We've had less than 1% people that have either just said, I don't want to do this anymore, or a couple people have said, well, I didn't really want to do all this surveys, I just wanted to get tested. But by and large, people have been real receptive to what we're doing, and our response rate's been really good. The HIV counseling testing, as I mentioned, is done in a separate room, and it follows state guidelines for risk counseling and post-testing follow-up. It's all done by ARCW staff who are state trained and certified to do HIV testing. Confirmatory test. One of the things with confirmatory testing, when you talk about privacy and confidentiality, is everybody knows this is a one-shot study, right? So people come up, they see us, and they go back. If someone has a positive confirmatory test, or one person had a false reactive where we had to bring them back, if they come back upstairs, everybody's going to know they're coming back up for a reason they shouldn't be coming back up. So one of the things we do is have them come out And we actually meet with them in the nurses station completely separate from the unit so that there's no real knowledge that someone's coming back to see us to get test results in that sense. And it was one of those subtle ways that we had to try to protect confidentiality. The other thing that we've done is we've set up, to get out all the HIPAA stuff and sort of stuff, all of the medical treatment, ARCW conducts the test. If there's a positive or a known, they link them to their treatment system. Once someone is identified as positive, they go out of the research protocol. So really the research protocol is about the linkage, but we let the treatment be standard of care that ARCW then handles as they would any other person that they had tested in a prison, in other prisons. So they follow their own standard protocols. In this case, when there's a new positive, their standard protocols that they use in other prisons is to notify the nursing staff and the social work staff so that if there are any medical or mental health or psychosocial needs, they can be followed up. And then they also initiate a process of transitional care with the medical staff at the prison. Okay. Medical records are maintained in accordance with HIPAA and other protections. What we get is the de-identified sort of aggregate data of people that are referred, but all that data is extracted by ARCW medical staff, not the research staff. So again, we've really tried to put a firewall in between the research and the treatment. And then they also handle all the partner notification mandated by City Health Department. Okay. Similarly, the high-risk negative referrals, if someone's identified as high-risk negative, they go into ARCW standard recruitment protocols and in terms of getting information and other things like that. And we only get, again, information about the aggregate sort of response to that. And we have tight firewall. We have to collect a lot of personal identifiers, social security number, mother's maiden name, et cetera, to access. One of the things we're looking at is who shows up on mandated reporting HIV and STI list 2 years after release. So we have that information, but that's maintained separately and not linked with any data. Okay. So finally, let's talk a little bit here about creating an environment for best practices. And I think all of us have a lot of knowledge about what to do around HIV testing, prevention, treatment in terms of standards of care, what works, what doesn't work. I think really the essential thing, especially in working in an environment like corrections, is creating an environment that allows for best practices as opposed to what are the best practices. And that's the question that we really need to be driving. And so, do people who are incarcerated have safe access to needed services? Do they understand their care options and potential benefits or side effects? Do they have knowledge to freely consent and capacity? Do they have assurance of confidentiality of their records and privacy of those records? Okay. Do they receive services in a system designed to provide optimal care in a private and confidential setting? Do they receive care from a provider who views them as an autonomous patient, a person, rather than a person in confinement? Do they get broader psychosocial needs addressed? One of the things I talked about yesterday was people, not prisoners, right? Prison is a state of their life, but they start with the person. In competent care, you have to start with people who are incarcerated as people first. And do they get transitional health care and management? So culturally competent care, in conclusion, is not the delivery of services to people who are incarcerated. Rather, it's the delivery of services using best practices to people who are incarcerated. And I emphasize the emphasis on people, not service. We know what the service should be. An environment which does not support delivery of culturally competent ethical services can never truly deliver best practices. And I will leave you there. Thank you.